Without saying it. It's really awkward to do it, you know.
Where do you have to point it? Probably at the projector.
Turn around and point here.
Point it at the projector.
Well, no. It'll click.
Go
I'm
to
saying for
the
the
pointer.
Right.
If you use the mouse, then
Yeah,
it shows
use
on
the
the
mouse.
screen.
No.
Well, it shows on the online.
Oh,
If
it
you use
does. It
this,
will show
yeah.
up online. Okay. Makes sense.
There's no time, I guess.
For 2020, we hope you guys really continue to enjoy it and really welcome y'all's participation. Please share with your colleagues and anybody else you know that may benefit from coming in. We'd love to meet them. Just looking forward, next month we have Ray Klopowski who's going to be talking to us about adolescent and pediatric ankle injuries. For those of you a little less familiar with this lecture series, we do this once a month, usually on the second Tuesday of the month. It's really meant to be just kind of a time for us to come in, have some coffee, some breakfast, and a short lecture series of good discussion and Q&A. Again, we really welcome y'all's participation. We really want discussion. We want this to bring about discussion and make this as beneficial for everybody as possible. This is a series that is, there's no financial gain from this. We have nothing to disclose. This is a free educational series. We also would like to take this time to mention our POSE series, which is our Pediatric Orthopedic Education Series that's going on in Dallas. We do this annually in Dallas. It's in February, as well as our annual Sports Medicine Conference that'll be coming up in May here at this campus. So if you guys want any other information on that or would like that, just let us know. Grab any staff member and we'll get that to you. For today's talk, we have an all-star lineup. We have our entire sports medicine staff here to kind of go through things with you. We're going to cover overuse injuries in our pediatric and adolescent athletes. So this format will be a little different than some of the others. We're going to have each speaker come up and present. Once they finish presenting on that topic, there'll be time for maybe one or two questions, so raise your hand and we'll get to those questions. If we don't get to your question, just hang on to it. At the end of the series, we're going to save about 10 or 15 minutes to kind of have a panel discussion. Unfortunately, we'll lose two of our speakers. They have other obligations, teaching obligations downtown, so they'll be jumping on the toll road. But the remaining three speakers will be here to kind of cover any questions that you guys have. All right, without further ado, we'll start out with Dr. Miller, who's going to be covering Osgood-Schlatters. Thank you.
Good morning. Thank you guys for coming. We'll get going here. I'm Shane Miller. I'm one of the pediatric sports medicine non-operative physicians here at Scottish Rite. And I'm going to discuss Osgood-Schlatters Disease today. I have no disclosures, unfortunately. So just a brief sort of introduction here. I know a lot of you guys treat pediatric patients and adolescent athletes on a regular basis, but one of the things that makes them unique to us, other than developmentally they are skeletally immature, their growth plates are composed primarily of cartilage, and so are susceptible to both acute and overuse injuries. We talk about the growth plate being the weak link in the chain, and so that's part of the reason that we see a lot of growth plate issues. And when we talk about common overuse injuries today, we're discussing common growth plate overuse injuries. So just to review, the physis is the growth plate itself, in through here. The epiphysis is the longitudinal growth center. The metaphysis is sort of the portion that's widening into bone here. The diaphysis is the shaft. So an epiphysis adds length to a bone, but an apophysis with an A adds shape or contour to a bone, and it's typically a spot where a muscle or tendon will attach. And so some of this, what I'll talk about, is a little apophysitis. So our case is going to be a 12-year-old male basketball player who comes in presenting with gradual onset of anterior knee pain. His pain is worse with activity when he kneels down or when he bumps it on something. He doesn't really recall any specific history of injury or trauma to the knee. And upon presentation, you notice, or he complains of localized swelling, and he has tenderness over the tibial tubercle. So, Osgood-Schlatters disease, what is it? This is tibial tubercle apophysitis, also known as Osgood-Schlatters disease. This was described by Dr. Osgood and Dr. Schlatter back in 1903, so it's been recognized and around for a long time. But the name is still very scary to families, so I reassure them that it is not a disease that Dr. Osgood and Dr. Schlatter wanted to name something after themselves. And so, again, it is an apophysitis. This is a repetitive traction induced inflammation of the tibial tubercle apophysis. You can see that the extensor mechanism comes over the top of the patella, the quad tendon and the patellar tendon, and the attachment on the tibial tubercle apophysis with repetitive knee extension, running and jumping. That repetitive traction causes inflammation, and so therefore they will have tenderness over that tibial tubercle. So more common in boys than in girls. A little bit older boys, about 2 years shift over the girls. It can be bilateral in about 25 to 50% of patients. They are usually gradual onset of symptoms due to repetitive activity without a specific injury, or sometimes they'll present saying that they have fallen on a flex knee, and that may have initially aggravated the pain, and then they've continued to have activity-related pain following that. Oftentimes we'll notice that they'll have tightness in their quads or rectus femoris. And parents will often note that they've had a recent rapid period of growth. They are highly active youth athletes, and sometimes overweight and obesity may be associated with this. The chief complaint is typically pain and swelling. Often they'll notice a bump, and that bump may be concerning to them. Sometimes families are presenting more because they're worried about the bump itself than they're worried about the pain, so reassuring them about that. Typically aggravated by activity. On exam, they'll have point tenderness directly over the tibial tubercle and the distal portion of the patellar tendon. There's often enlargement of the tubercle, which is firm on palpation. And sometimes when you fully passively flex their knee and add tension to that quad tendon, that will also exacerbate their symptoms. Imaging is not necessary in routine cases, but if you want to get x-rays, an APN lateral film may sometimes be helpful to exclude other pathology. And on the lateral radiograph, you may see some of the fragmentary ossification there. So you can see here where the red arrow on the right is showing the soft tissue swelling overlying, as well as some of the fragmentary ossification, and then sort of a typical presentation of what you may see on a patient here when you walk in the exam room to evaluate them is that bump, that classical bump there. So reassurance, I think, is really important, letting the family know that this may come and go for a couple of years while they're actively growing in that particular area. And our goal is to help manage their symptoms so they can continue to participate in their sports. Ice and NSAIDs, anti-inflammatories, may be helpful, especially after activity. Oftentimes I'll recommend an infrapatellar strap, what is sometimes referred to as a CHOPAT strap or a patellar tendon strap. But stretching, I spend a lot of time focusing on stretching with them to try to loosen up and give them more flexibility and decrease the tension of that patellar tendon on the apophysis. If they're not getting better, oftentimes we will refer them for physical therapy, but most of the time we can try with a home program initially. In some recalcitrant cases, you may consider prolotherapy or hyperosmolar dextrose injection. Usually when I consider this and discuss this with families, the pain's not that bad. They don't want a needle in their knee, and so they're usually say, okay, I'm not that bad. I'll do my stretches now, and then they'll improve, but we will do that sometimes. We don't recommend steroid injection into the area. And very rarely, especially after a skeletal maturity, they may be referred for surgical removal of the ossicles if they remain symptomatic. I do recommend protective padding so that when they don't fall on it, it continues to cause trauma and pain and through there. But really, they're allowed to participate as tolerated. If they're not limping, they're not having a lot of pain, I think it's fine for them to participate with this. It is rare to have an avulsion fracture of that spot. So again, relative rest as opposed to complete rest. Activity is tolerated. Just one other caveat is to think about is a similar presentation is Sinding Larsen Johansson, or SLJ. This is apophysitis at the inferior pole of the patella, so very similar, just a different part of the patellar tendon there, a little bit younger age, and sometimes a little bit more challenging to treat, so sometimes you may want to refer those on a little bit sooner. So key recommendations: relative rest as opposed to complete rest. I really think stretching makes a big difference. Patellar straps sometimes will help with symptoms. Ice after activity, NSAIDs as needed. Physical therapy in some may be helpful. But really spending a lot of time reassuring and educating the family on what this is and that it's going to be okay. All right, and I'm done. One or two questions?
Does anybody have any questions for Dr. Miller? Dr. Ellis seems like he may have a question.
What do you think every kid that comes in with tibiotubercle pain that needs an X-ray? And if so, when do you recommend getting an X-ray?
Yeah, so I think if they come in with the classical presentation of tubercle apophysitis or Osgood-Schlatters, depending on your setting, then they don't need X-rays. I think if there has been trauma and they've felt a pop or heard a pop or there's been some acute inciting event, then those I tend to recommend an X-ray because there may be an increased possibility of an avulsion fracture. But otherwise, we don't necessarily think that they routinely need X-rays. You want to add to that?
I have another question. So you talk about doing prolotherapy or intervention to Osgood-Schlatter because they can be fairly resilient for long periods of time. How long will you treat, or how long will you keep a child out of activity before recommending an intervention?
Yes, so in terms of the prolotherapy, I think that those are the ones that are struggling to continue to participate in their activity. The ones that are saying, yeah, my knee hurts, but I'm doing fine. I don't really have any limitations functionally or pain-wise. I'm not having to sit back, and they're usually content with it. But the ones that are struggling and are not able to perform at their higher level functionally, or the pain is just so taking them over, then I will discuss that option with them. But I usually don't discuss that until we've given them several months of conservative management, and I've ensured that they're following through the recommendations and that we've maximized them from a flexibility standpoint. Thank you, guys.
Thanks, Dr. Miller. Next up, we're going to have Dr. Wilson.
All right, thank you. Well, we're really happy to have everybody here and those who are online, and really appreciate kind of the community involvement and the interaction with you guys. So we're going to talk about Little Leaguer's elbow, and a lot of this is going to be broad strokes because it's familiar to you guys quite a bit, and then we'll just kind of talk about some concepts. The term Little Leaguer's elbow really encompasses pathology on the medial and the lateral aspects. So medial epicondylitis, an epicondylar avulsion, a capitellar OCD, or ulnar collateral ligament tears, and they kind of occur in that order temporally, and you can see the stress pattern that occurs on the elbow there with throwing. And so when we think about throwing, the throwing cycle is a very, very specific biomechanics cycle. To be efficient, pitchers all kind of gravitate toward almost the exact same motion. And it puts that arm and that external rotation and valgus and puts some unique stresses on the elbow. The problem is, in Little League, the elbow looks like this on the inside. There's lots of these little growth centers. And so those little sort of diagonal shaded lines, that's the ossification center of the bone within the developing cartilage. And so that's an immature structure, and it's really not designed necessarily for the type of loads, both kind of direct loading as well as shear stresses that can be placed on it during that throwing cycle. And so when you get the arm in this position and you get that medial tension, lateral compression, and there's some shear and rotation that goes into that, these little growth plates are all under a lot of stress. And again, it's not necessarily the growth plates, but it's the interface between the cartilage and the bone that's developing inside. And so the problem is not one or two episodes, it's repetition. And that's the theme that we have this morning. But this is kind of a classic example of repetition. And it's pitch volume, year-round participation, sort of the trying to play on a select team where there's so many games being played over a short amount of times. And then kids that are really good end up pitching and catching. And so it's just a volume problem of the stress on those little structures. And the literature has really continued to bear this out. This has been something that we've known for a couple of decades, but really a negative relationship between all numbers of pitches and future performance. And it's volume, not just in a game, but over a season. And so this is a classic example of just too much over a sustained amount of time. And when kids play at earlier ages, when they play for longer periods, those are positively correlated with some of these injuries that we're talking about. And we see some of these happen, some of these injuries really peak at an age where kids really have those really immature structures in their elbow. So it's basically just these forces are across a very immature structure. So the history is really important. You have a loss of velocity that you can look back and talk to families and talk to kids. And so these are things that are really easy to recognize if you're looking for it, if the coaches are looking for it, if parents are informed. So education is really one of the most important things. Looking for loss of velocity and loss of control, those are functional things. As the elbow starts to have problems, the kid may not even know why it's happening. And then the elbow will lose extension, and that's often a silent problem. And kids will, in retrospect, you ask them to say, oh, yeah, it's been a while since my elbow would straighten. I just kind of ignored it a little bit. And then they develop medial pain after throwing. They're fine during the game, and then it hurts later, and then they get pain with throwing. And then sometimes there's a sentinel pop while they're throwing or mechanical symptoms. And it really is kind of occurs temporally in that order from top to bottom. And so what do we see on exam? We see that loss of elbow extension. You look at the elbow of the throwing arm compared to the contralateral side, and it's lost extension. The whole joint is inflamed. There's some synovitis. There's some tension in the flexor musculature, and that causes a flexion contracture. They have medial pain, and that, again, is temporal. At first, it's over the flexor muscles. Then it comes to the medial epicondyle itself, and then the ulnar collateral ligament. And you can exhibit some of that or provocative testing with valgus stress testing on those structures. You can kind of find that point tenderness. When it's epicondylitis, it's in the muscle belly. As it gets to be more of a periosteal or avulsive change, then it goes to the epicondylar insertion. And then kids who have capitellar problems, they just have posterior lateral vague pain and sometimes develop mechanical signs. So beyond the physical exam, again, history, physical exam, we start to sort of, say this is pretty clear. How's your elbow moving? Do you have mechanical symptoms? Do you have a pop? And so sometimes imaging is warranted. We see medial epicondylar avulsive changes on the x-ray. You can see capitellar radiolucency with OCDs. And then, of course, advanced imaging. We can use ultrasound for quite a bit of this, but the gold standard remains MRI to really see not only the ligamentous structures, but also the avulsive changes that can occur. So, overuse, the answer is always rest. Change the pattern, decrease some of the stresses. So we put these kids into forced rests, and then we do scapular and shoulder and forearm strengthening, shoulder stretching. We work on form. We work on throwing limits. Surgery, when needed, we can address the avulsive changes of the medial epicondyle. We can address the capitellar osteochondral problems and ulnar ligament reconstruction. These are big surgeries. They put kids out for quite a while, and most of our literature shows that kids have trouble returning to the same level. So prevention is the key. You really want to look for the problem, right? I mean, it's pretty easy to find if you're looking for it. So kids that get this have a history of a high volume of throwing. They're kids who talk about a previous injury or having arm fatigue at times. And so it's really just asking these kids, training the coaches, working on proper form, working on progressing their mechanics before they try to throw too much or too difficult of pitches. This is a concept that just visually is a really nice one to look at. It has to do with your pitching mechanics. Oral Hershiser there on the left was known for great mechanics. He had a long career. And Sandy Koufax on the right had a very, very short, brief, wonderful career, but very short. And you see where their hips are, and you see what that does to their upper body. Many of you are therapists or athletic trainers kind of understand that concept. It puts the shoulder girdle and the elbow in a much less advantageous position. And this is what kids look like when they're young, and as they start to get a little bit better, their rotation and their mechanics change. So that doesn't look very good at all. It looks like it hurts. And that looks a little bit more athletic, and that's what we're looking for. And there's been multiple studies talking about how the lower body affects upper. So for prevention, we work on not only the form, but on the mechanics and the strengthening with the therapy team. Pitch counts are very important. Again, this is a volume problem. And so you attack the whole problem in terms of how much they're playing on concentrated teams and specialty teams, but also the pitch counts within individual games, and that's been shown to be critically important. So we put them at forced rest. We want to rehab them, strength and stretch. We want to evaluate their form and then put them into a progressive throwing program, and they have to have no pain when they go back. So finally, education, I think, is really the key for this problem. All of us, particularly parents who are now kind of hovering on the front line of their kids. No concurrent pitching and catching, really looking at throw counts or seasonal throwing volume, really extreme caution with year-round play and select teams, and look for elbow loss of extension and ask kids about the pain. Those are pretty simple concepts, but they go a long way for prevention for this problem. All right, whirlwind tour of the elbow. Any questions? Fantastic. Dr. Ellis.
Any questions for Dr. Wilson? Dr. Ellis
Yes.
does have a question.
Yes, ma'am.
Actually, I'm going to skip Dr. Ellis for a minute.
So we know that pitch count is the most concerning, but are there certain pitches at ages that you're worried about or that you see more prominent?
Yeah, interestingly, people have looked at type of pitch quite a bit, and I think I had it in here somewhere, but basically the answer is it's volume over type of pitch. And there used to be a lot of concern about curveballs or breaking pitches, but when they started to look at that, what they really found was the correlation was the kids who were throwing breaking pitches at an early age were just really good throwers, and they had a high volume. And when they looked at the curveballs versus the volume, it's the volume that was the problem. And so it's not, I'm sure there are, there's always cases where it was a particular mechanics problem, but the answer is really the kids who are at risk threw those breaking pitches because they were good at an early age and they had a huge volume of pitching behind that problem.
As far as technique, do you see, or I guess more injuries based on somebody that has like the side releases?
Yeah. Yeah, so the mechanics are incredibly important. And, there are people who, you see these odd mechanics at the upper levels of college and major, but those are the small little numbers at the bell curve. Most people fall into a very, very narrow range of their mechanics because once you get out of that hip rotation sequence or how far your arm comes back, you start to put so much stresses there that the number of kids that fall by the wayside with those odd deliveries are astronomical compared to the few that you see that make it. So yeah, it's a pretty narrow window of appropriate mechanics, yeah. All right, in the interest of time, I think we'll move on. Thank you, guys.
Next up, we have Chuck Wyatt, who's going to cover Little Leaguer's shoulder. So we're going to move up a little bit to the shoulder.
Great. Again, we're really glad to have your participation and looking forward to a great lecture series in 2020. So I'm going to talk about again. My name is Chuck Wyatt. I'm a pediatric nurse practitioner, and I'm going to talk a little bit about Little Leaguer's shoulder syndrome. I have no disclosures. So what is it? So the medical term is proximal humeral epiphysis, or Little Leaguer syndrome, shoulder syndrome. It's the other Little Leaguer syndrome. Most people have heard of Little Leaguer's elbow syndrome, and what it is, it's a painful overuse condition of the shoulder that causes widening of the growth plate at the proximal humeral growth plate. It occurs primarily in the dominant arm of baseball pitchers, but it can occur in any other in other overhead sports like such as softball, tennis, volleyball, and swimming. And what are the causes? What are the causes and risk factors? So the pathophysiology is the repetitive shear forces that are imposed on the unossified cartilage of the proximal humerus physis. And so when we think about the pitch sequence and the mechanics of the pitch sequence, there's a tremendous amount of force that's placed across the shoulder as we rear back and the arm goes into a tremendous amount of external rotation and the arm is accelerating backwards, and then as we go to slow down as we're coming through, there's a massive amount of rotational forces that are imposed on that growth plate. And anytime we're talking about literally shoulder syndrome, I think it's important to look at what normal shoulder anatomy is in a pediatric patient. And so where my arrow is there, that's what a normal physis looks like of the proximal humerus. So our case is so this is a 12-year-old male who plays both pitcher and catcher. He plays for 2 teams. He plays year-round. He's had pain with throwing for 4 months. And, the reason that he actually presented was, I just had I had pain with throwing, but, I'm sort of used to that and all. But now I have pain when I'm not throwing. He's having pain with ADLs. He has pain just to lift his arm in general. And so, and then when we look at his X-rays here, we can see. You can see there's even a little bit of fragmentation that's at the anterolateral aspect of the growth plate here. You see widening of the growth plate and almost a ground glass appearance when we look at the standard AP of the shoulder. And then when we look at a cross-tabulateral shoulder, we also see a tremendous amount of widening of the growth plate there. And you can actually see that there's actually even a little bit of rotation that's actually occurred with this kid, because this kid is on the severe end. He's on the severe end of the bell curve. And the thought of the primary reason why this occurs is the rotator cuff muscles attach on the epiphyseal side, so above the growth plate, and then all the other major muscles of the arm are attached below it. And so there's again, that's where we get our big shear forces, big rotational forces that are happening, and this is occurring over and over and over and over again, and which causes this condition. Risk factor is being a pitcher or being a catcher. So about 80 or 93, 94% of all athletes who have little leaguer shoulder syndrome are either a pitcher or a catcher. It can be, you can see it in other positional players in baseball. It typically occurs between the age of 12 and 13. That's your highest incidence. Probably 50% of all athletes that get this condition are either 12 or 13 years old. Although we do see it in kids as young as 8 and as old as 15. As long as that growth plate remains open, you can get this condition. The other things to consider. If you take care of lots of athletes, is that it is not only males. Females can get this condition. Other athletes besides, as we talked about, other athletes besides baseball players can also get this condition. We do see it in softball some. My own daughter actually had a bit of this condition that we had to deal with for a little bit, where we were hitting, we were using weighted balls, practicing hitting, and while returning the ball to me, she picked it up and she threw it to me. And which is a really, really bad idea. And so she didn't have a pop or anything like that, but she didn't, very shortly thereafter develop pain around that growth plate with throwing. We also see it in tennis players. I have had several tennis players in my practice who present. Typically, it's after they've spent a lot of time working with a new coach. They're working on their serve, and they just hit just millions and millions and millions of serves, working on a new technique or whatnot over a period of time. And so if you think about tennis players get way up high like this, massively externally rotated, lots of torque coming down, again causing that shear force. And so it can also not be in the dominant arm. If you have a swimmer, sometimes swimmers can present with this condition as well, and it may be in the non-dominant arm, again just because of the shear forces that are placed across the growth plate. How do you diagnose it? So Lilliger's shoulder syndrome, it's primarily a clinical diagnosis. History, your history is extremely important. They'll have diffuse pain with throwing in the beginning, and then they may have pain with ADLs in advanced stages, just pain putting on their shirts, just trying to lift the arm overhead. Again, it's a clinical diagnosis. You don't have to necessarily have x-rays, particularly in the early onset of the condition where they have a recent onset of shoulder pain and they get to you pretty quickly. You don't necessarily have to have x-rays to do it. Your physical exam, they'll have focal tenderness at the physis, and it's typically on the anterolateral aspect of the physis. In my opinion, the best physical exam for this is pain with resisted internal rotation. And so I'll often block the back of their shoulder with one hand and then have them try to internally rotate with me, and that'll reproduce their pain. I think that's the best exam. Oftentimes these kids will have glenohumeral internal rotation deficiency where they've, because the back of the shoulder gets tight with throwing, and then they'll have limited internal rotation. That's highly associated with Lilliger's shoulder syndrome. When you do get x-rays, which oftentimes you will, again, you don't absolutely have to. If your diagnosis is in question, sometimes contralateral films are useful, and usually just a single view of single shoulder external rotation view is useful. An MRI is rarely ever indicated. Treatment and prevention. So treatment is forced rest for 6 to 12 weeks, usually more along the lines of 12 weeks. Physical therapy for sleeper stretches, because they oftentimes have glenohumeral internal rotation deficiency. We do periscapular stabilization and strengthening of the rotator cuff muscles. And then an interval throwing program begins when they're pain-free. So if a kid comes in that's super symptomatic, I won't even start an interval throwing program until they're at least 6 weeks in. Let them completely calm down. Prevention is training with educated coaches, learn proper form, working on trunk rotation sequence, strict adherence to pitch counts. Pitch counts do matter. They need to avoid pitching with fatigue. There's pitching guidelines for you guys that I've attached for you. When can they return to play? So they can return to play when they're completely pain-free and they've completed an interval throwing program. And then, as we return them to play, we really stress the importance of keeping up with sleeper stretches for maintenance. The kids who are throwing need to do sleeper stretches and maintain their internal rotation as long as they're playing. So non-baseball athletes like volleyball players and tennis players, if they, fine to send them back at 6 weeks if they're pain-free. And key recommendations for practice. So the incidence of Lilliger syndrome is rising probably 8% a year out of one study. Year over year, 8%. So it is increasing. And encourage diversification. Encourage your patients to participate in other sports, and so we can develop well-rounded athletes. Thank you. Question?
Any questions for Chuck? Chuck, I have a question for you. So when you have, particularly in this area, these families that have put $10,000, $15,000, $20,000 into their sport, and they've paid for the season, they've invested a lot of time, they're not always willing to say, I'm just going to sit out. That's not really what they want to hear. And so when you have that family, how do you feel about suggesting playing a different position or moving to a different position, maybe?
Yeah, I think I think that's a great question because that does come up from time to time. If they're not having pain with activities of daily living, you can consider allowing them to play first base. The distance of your throwing is much shorter. The quantity of pitches or throws that you have are much lower, so that's okay. Oftentimes we'll recommend that they work on hitting, work on their bunting. I don't let them hit if they're if they're really symptomatic. I don't let them hit. But when they're pain-free, let them start hitting. Tell them to work on their bunting, that sort of thing. You just try to be creative about things that they can do to be proactive.
Any other questions? Okay, next up is Dr. Jane Chung. She's going to be covering Sever's apophysitis.
Good morning, everybody. Thank you for joining us this morning. And moving along in the overuse-related series, I will be speaking about Seaver's disease, also known as calcaneal apophysitis. I am a pediatric non-operative sports medicine physician here at Scottish Rite, and I think we are almost there. So we're going to start off with a case. So we have a 10-year-old male who comes into your clinic, and he's complaining of heel pain that's worse with running, especially after soccer practices when he's running in his cleats. And the pain seems to resolve when he's resting. His mother states that he had a similar complaint last season during soccer season as well. So what is Seaver's disease? So it is inflammation and irritation over the calcaneal apophysis due to the repetitive traction and microtrauma of the Achilles tendon pulling over its bony insertion on the calcaneus. And this only occurs in skeletally immature patients, particularly who participate in a running sport. And so an apophysis, as Dr. Miller went over, is a growth center that adds contour and shape to the bone, and oftentimes a muscle or a tendon inserts. And in this case, it's the Achilles tendon that inserts over the calcaneus. And the apophysis is a much weaker link, and so it's weaker than the actual tendon that attaches at the bony insertion, and so it frequently becomes inflamed and irritated. And this is a overuse traction type phenomenon. So we examined this 10-year-old kid on an exam. He's got lots of pain over the posterior and medial aspects of his calcaneus. You squeeze the heel and it hurts. So we call that a positive squeeze test with medial and lateral compression over the calcaneal apophysis. You have him hop around in clinic and he's complaining of posterior heel pain as well. And when you examine him, he has really, really tight calf, gastroc, and Achilles tendons as well. So some of the differentials that you want to keep in the back of your mind when you're examining a skeletally immature patient with heel pain, is it a retrocalcaneal bursitis back there? Are you thinking of a calcaneal stress fracture perhaps? An ostrigonum, which is an accessory ossicle that can sometimes live in the posterior aspect of the ankle. Is it more of a tendinosis type of thing? Plantar fasciitis. So these are some of the differentials to kind of keep in the back of your mind. So what causes and what are the risk factors for this? So again, frequently in a skeletally immature child with activity-related posterior heel pain is what they're going to be complaining of. And oftentimes the story goes that they just started a new soccer season or they just started their basketball season. So we oftentimes see it at the start of a new sport or season. And again, having tight Achilles and calf muscles can put them at increased risk due to the increased tension and the traction that the Achilles is tugging on over the calcaneus. So these are diagnosed clinically. So it's a clinical diagnosis. Oftentimes, x-rays are completely normal. But if you do get them, they may show some increased sclerosis and fragmentation of the calcaneal apophysis on the lateral view. And so here on the left-hand side, you see our 10-year-old male who has a normal-looking calcaneal apophysis. On the right-hand side, you see that there's perhaps a little bit more increased sclerosis over the calcaneal apophysis right in this area. And this is the lateral heel view of a 9-year-old soccer player. So x-rays typically aren't very helpful. But if you are concerned about some other bony pathology, then certainly they can be helpful. These calcaneal apophyses appear around 8 to 9 years of age and tend to fuse around 12 to 15 years of age. Obviously, it occurs a little bit earlier in the females due to sooner skeletal maturity than males. So pain can be constant or intermittent. I always tell patients that Seaver's disease is kind of like the Osgood's of the heel, and the presentation can be varied. And so I tell parents it can present in like a spectrum. So in the far left hand, you have those kids with mild and kind of going on to moderate symptoms. In the far right hand of the spectrum, there can be kids who present with very severe symptoms. And so oftentimes it's intermittent, or sometimes if it's progressed, then the symptoms can be more constant. Typically, they will complain of pain after activity, so after soccer practice, and then it can progress to pain during activity, so while they're playing sports. And ultimately, if it progresses even further, then it can limit their physical activity. And so they may complain of pain even with walking and doing everyday activities. At the extreme end, sometimes these kids may have difficulty ambulating. So they may walk in your office with a limp or hobbling or kind of hopping on the other side so that they are not applying pressure in the contralateral heel. This can occur in about 50 to 60% of the cases on both sides of the heel. And it is more common in males than females. And the peak age that we see this is around 10 to 12 years of age. So treatment is conservative. We encourage activity modification, relative rest. If the kids complain of some achiness and soreness of the heels after a soccer game or basketball practice, I say, rest, ice, stretch. However, if the parents are like, oh, we see them limping out in the field or in the court, they're hobbling, then in those cases I tell parents, if you see your kid limping out there, bring them in, have them take a break, and then, send them back in. Because the worst thing you want for it to happen is for them to fall and have another injury because they're limping and having trouble ambulating. So ice, I like to recommend freezing a water bottle, and then the kids can kind of do a rolling ice massage while they're sitting so that the ice kind of rolls on the bottom of their heels. The heel is kind of a difficult area to ice, and so I find that works really well. Anti-inflammatories as needed. We have heel cups that we also like to prescribe, and so these are gel heel cups that the kids can put in the back of their heels, and it does provide some comfort and relief of the traction of the Achilles kind of tugging in that area. I also stress the importance of heel cord stretches, so some calf and Achilles stretches, which I will show in a little bit. Immobilization is rarely needed. However, if the kid comes in obviously limping or not wanting to bear weight on that side, then a brief course of immobilization with a boot or maybe even crutches for a little while can be beneficial for some of those kids who do have more severe symptoms. And then if all of these fail, then physical therapy can certainly be considered as well. So on the left, these are the heel cups that I was talking about. So these are really easy. Kids can put them in their school shoes and then transfer them into their soccer cleats or baseball cleats, and they really like them. It's easy, and it tends to alleviate a lot of their calcaneal discomfort as well too. This is Thule's, and this is a neoprene type of ankle sleeve, and it has heel cups that are stitched into it. And so these are very helpful for those athletes who participate in barefoot sports, like our dancers and our gymnasts. And so many of our gymnasts who train 10, 15 plus hours, and they're skeletally immature and they've got severs, I will recommend this, and these work pretty well. They work well. Again, Achilles and calf stretches are very, very important. You don't need any fancy equipment. Oftentimes we will teach them how to do towel stretches, so stretching their heel cords with just sitting on the ground and using a towel to stretch their Achilles. Calf stretches can be done against the wall. You can isolate the soleus muscle as well. And then on the stairs or on a stepping stool, they can do toe raises to stretch their Achilles tendon as well. So when we talk about return to play, these are self-limited conditions. We reassure them that there is no long-term sequelae, and return to play as symptoms allow. However, if the child is limping with the sport, then we do advise resting. And you can kind of feel how the patients are. If the kid's like, oh, I'm still able to go out and play soccer, but the mom's like, he's just complaining of heel pain after the games, then rest, ice, stretching. However, if a kid is walking into your office and you notice that they've got an antalgic gait, they're having trouble ambulating, or clearly in discomfort, then you may consider shutting them down from the high impact related sports for a period of time. Cross-training on lower impact activities such as riding their bicycle or swimming, those are typically good activities that the kids can do in the meantime if they are needing to take a break from their high impact activity. So some key recommendations for your practice: always think of Seaver's disease with activity-related heel pain in a skeletally immature patient. Peak presentation is around 10 to 12 years of age. You want to really focus on the calf and Achilles flexibility, and you want to reassure that there is no long-term sequelae with this condition. Thank you very much. Do we have any questions? Dr. Ellis?
Coming.
As opposed to the shoulder and elbow, which we think is extremely detrimental to play with pain, what's your recommendation for a kid that has heel pain, whether they can play or not? Is it bad for them? Is there any long-term problems? Can they play through a little bit of pain?
Yeah, so it depends on their symptoms. If it's just mild achiness and soreness while they're playing or after they're playing, I don't put any restrictions on them. And so I tell parents it's just discomfort. Heel cups are really good. Stretch, pre-warm up, and anti-inflammatories as needed, and so it's not going to have any long-term sequelae. However, if they are limping out in the court, they are in extreme pain, then you always worry about, okay, are they going to fall and hurt or injure something else? And so in that case, I always say, maybe having them rest for a little bit, but it's activity as tolerated and then kind of modifying based on their symptoms. Any other questions? Great. Thank you very much.
Okay, and finally, we'll have Dr. Ellis, who's going to cover some hip apophyseal injuries.
Good morning. I certainly am. I'm excited that we got to bring this all together, because it's very. This is such a common thing that we all see, is these apophysitis and these overuse injuries. So it was quite nice for all of us to combine our heads and join us for one continual talk. I appreciate your all's patience, and apologize for some repetition, but I do think it's important. I'd also like to welcome all the online viewers too. We've gone digital, and we're really excited about that. So I think we have almost 20 online viewers today, so I certainly want to welcome them and encourage them to send us an email if you have any questions, because we're monitoring the website. I'm going to talk about hip and pelvis apophysitis, primarily around the pelvis. That's where we see it very often, and surprisingly enough, for such a common condition that we see so often, there's very, very little in the medical literature that guide us for our treatment. I have no disclosures. Starting off with two cases, and I really brought two because we got to talk about the whole pelvis. It's not just one area, but I got a 15-year-old female. She's a runner. She likes to run, track, really all year round. She does cross country in the fall, track and field in the spring. She's starting to have hip pain with running. Those are her images on the top there. Then we have a 16-year-old female. She's a gymnast, 25 hours plus per week, not uncommon for our patient population, and she has a little bit of back pain that she describes when she lands after overuse, not an acute episode. So we're going to go to apophysitis of the hip and the pelvis. I usually use the term Osgood-Schlatter of the hip. I use this term because everybody knows what Osgood-Schlatter is, but I said Osgood-Schlatter of the heel, the hip. So what is it? Apophysitis, I find sometimes I have to describe to parents, but apo is really Greek for away from, physis is growth, and then itis is inflammation. So these prominences that are your bony prominences that really are your secondary growth centers that get inflamed for many of the reasons that we've stated today, because the cartilage is softer and it gets irritated, and we'll talk a little bit more about that in a second. So when you look at this as an AP of your pelvis, and when you think about your pelvis and you want to talk about all the apophysis around your pelvis, there's quite a few. We've got them all over the place. And when you really want to take a critical look, it's all where these tendons attach to that create this traction apophysitis. So commonly we'll see the hamstrings at your ischial tuberosities. You've got your hip flexors, both at your ASIS and AIIS. And then you've got your hip abductors, also a little bit of hip flexors too around your iliac crest as well. And then your pubic symphysis, you got your abdominal muscles, your adductor longus, a few there. So you can see all of these muscular attachments to this cartilage secondary ossification is what causes this inflammation. And there's a particularly interesting curve that we use, we like to use a lot, that second peak during your growth spurt is really important and valuable, because what really happens, what we've alluded to, is you have all of these cells that reproduce right into your growth plate, and that's what happens when you go through your growth spurt, is you have an increasingly amount of cell formation. Now that weakens the extracellular matrix. And what happens at that point is you have microtrauma with repetitive overuse, and it causes these little minor injuries to that area. Well, when we don't give it time to heal or recover, what happens is it starts treating it like a fracture. They become bigger. And that's when you start developing these apophyses, because your body starts to react to that microtrauma and that soft cartilage of that bone there. So going back to a couple cases here, here's really what we see radiographically for apophysitis. You can see I got two images there. One at the ischial tuberosity, where your hamstring attached, that's on the left. And then up high at your ASIS, you see the irregularity. That just doesn't look like normal bone. It looks like cloudy bone. It's just not normal there. And so that really comes to light on our two cases here, in which you have a female runner that has pain when she runs, so her ASIS, where she has hip flexion, and then you have our gymnast, in which she complains of back pain, but it's really posterior gluteal region, and that's where she has the ischial tuberosity apophysitis as well. Now, we've described this as traction apophysitis because it's recurrent stress of these tendons as they pull against the cartilage. It is an overuse condition. We think it's because they work too hard and they don't allow their body to recover. It is almost always activity related. Sometimes we'll hear an acute episode and then we start worrying about a non-displaced fracture. And that's where, if you hear that audible pop, I may advance some of my imaging modalities and be more conservative, because I will worry that there's an apophyseal fracture there. I do think that our risk factors, generally speaking, are tight kids, the tight muscle groups. Now, I can't go over all the muscle groups of the pelvis, but generally speaking, we think they're tight. We think this happens early in season when they don't really properly condition before they start, and when they don't allow their bodies to recover. So it's the runner who runs all year round. In looking at each one specifically, now this is up here for your reference, but primarily your iliac crest. Your iliac crest has a lot of muscular attachment. It goes all the way to the back, so sometimes this can be confused with back pain. We see this in our long-distance runners, our gymnasts primarily, but we can also see it in other sports. Your AIIS, a little bit harder to diagnose on physical exam. It is from your rectus, so one of your hip flexors. We do see it in your long-distance runners as well as your gymnasts. Your ischial tuberosity, soccer players, gymnasts, primarily this is where your hamstrings attach, okay? And then you have your pubic symphysis here. I primarily see it in my practice in soccer players, but it's right in the center of your groin, and that's where we see osteitis pubis as well, or inflammation of the growth plate at that portion of your pelvis. Now, this is older than some of the other apophysitis we've talked about, and the reason is these secondary growth plates, they actually form and fuse later in life. So we think of this 14-year-old female, 16-year-old male as skeletally mature, but the reality is in their pelvis, it's clearly not. You can see that some of these, the appearances of these secondary ossification center and closures are actually much older than other parts of your body. So even your 16 skeletally mature male will still have apophysitis around their pelvis. And so you need to think about that in your differential. So how is it diagnosed? I find this to be a very easy diagnosis, particularly around the hip, because it's tenderness palpation right at that bony region, or you isolate the muscle group and they reproduce the pain with resistance of that muscle group. So when you look at the pelvis, your iliac crest, we can all feel our iliac crest. Even if we have a few love handles, you can still find your iliac crest around there. ASIS, same thing. You can always palpate this on almost anybody. Pubic symphysis, a little bit more of a challenging location to palpate, but oftentimes if this is tender, you've got the diagnosis as well. And then ischial tuberosity, I like to do this prone, and I'll do prone, and I like to put my finger right at the origin of the hamstrings. This handout here, I do not believe that these all need x-rays. However, oftentimes once they come to see me, we will get x-rays. The reality is I do think x-rays assist with the diagnosis if it is unclear. I traditionally refer to an AP frog of the pelvis. You can see even here, this gentleman who has osteitis pubis, you can see irregularity of that growth plate right in the center. This should be really smooth bone, and you can see how it just looks a little bit fragmented or even just irregular through there. Extensive differential diagnosis, you got to worry about things like intra-abdominal. Females may have some ovarian cyst, hernias you've got to think about, and certainly in these long-distance runners, I always worry about stress fracture of the hip as well. So how is it treated? Rest, rest, rest. You've seen that on many of our slides so far because we can't advocate that certainly enough. I do think cross-training is a reasonable option. With activity modification, you could change what you do. You don't have to stop doing sports. You don't have to stop, exercising, but maybe not running. Try something else. Do something for 60 days, 90 days. In severe cases, I do think weight-bearing restriction can help. Absolutely no running for 8 weeks. And then once they're pain-free, doesn't mean they can start going back to the activity. Oftentimes, I recommend them to wait 4 additional weeks before they go back. Now, when you think of beyond or some of the more resilient cases, I do think physical therapy, particularly in these athletes, is really important. And I advocate it for almost all of my resilient apophysitis. I do think that it's important, particularly during the rest period as well. I think passive motion early on can be extremely valuable. Once you're pain-free, you can start working on some gentle stretching, but don't overdo that early on when they're still in the inflammatory phase of the condition. Muscular billets, sometimes this is because one area is too strong and the other one is not compensating, or there's compensatory problems occurring. And physical therapists are teaching me a lot about this frequently. So muscular balance could be really important. There is a few reports of this in the medical literature about a bone stimulator, small case series. Don't use this routinely in my practice, and it can be very, very expensive. Surgery and the use of biologics. On some resilient cases, I do think that this may be worth discussion. I've had a few patients in which we've had this conversation and even proceeded to the surgical, but I'm afraid that it's just too early to really know if there's a scientific, really great rationale behind it. So it is a common overuse condition, and it is in the older adolescents, talking about hip and pelvis apophysitis. I do think the diagnosis is primarily clinical, and that's really a bit of common theme for all areas of apophysitis that we've talked about today. And the treatment is rest. It really is. We cannot mimic this with anti-inflammatories or special physical therapy or special injection or PRP or blood products. The reality is they've got to rest or change their activity. If we want to augment that with some other modalities, we could do that, but we really have to emphasize that rest is the primary treatment for all of these conditions. So thank you very much. I appreciate your time and welcome any questions.
Guys, we're actually, in the sake of time, we're going to go ahead and have the panel come up to the front. Sorry to cut you off on those questions, but if you do have a question for Dr. Ellis, we can start with that with our panel. But if we could have everybody from the panel just have a seat up in the front in those 4 chairs, and we'll go through a quick Q&A session and kind of generate some discussion on some of these. First, is there any questions for Dr. Ellis in regards to the pelvis and the hip avulsion injuries? Yes, sir.
I deserve a few.
All right, our first question here.
Yeah, how, because I've seen a couple avulsion fractures at the hip. So what are some of the key differentiating diagnosis for that compared to apophysitis?
Yeah, I think that's a great question. Number one, I don't, to date, I do not believe that having apophysitis puts you at risk of having an avulsion fracture. I think that's still unclear. Number two is it's all in the history. I think apophysitis is an inflammatory condition with an insidious onset, kind of slowly comes, happens with activity, gets better when you don't do activity. I think an apophyseal fracture is usually I landed, I heard or felt a pop, or I had sudden pain, and now I have pain all the time. And so that's how I would distinguish two of them. And I do think they're dramatically different practices because the avulsions I will remove from activity and treat it almost as if it is a fracture. Apophysitis, we also remove them from activity, but it's a little bit more slow going as well to treat the inflammation.
Just a quick comment on that. There's a little bit of debate about this with Osgood-Schlatters, whether Osgood-Schlatters can be a precursor to put you at increased risk for a tibial tubercle avulsion fracture. And I think, like Dr. Ellis said, the literature even on that is unclear. And the problem with that condition is Osgood-Schlatters is so incredibly common in the adolescent population that if you look at that and ask that question of all the people who end up getting a tibial tubercle, you're going to get a significant number of kids who say, yes, I do. But trying to study all kids who had apophysitis, and comparing them, we just don't have that data. So I think that's a little bit different than the pelvis. We certainly don't hear kids that have pelvic apophyseal fractures talk about a prolonged period of apophysitis. Right.
I'm wondering how you guys answer the questions from the parents regarding dietary modifications, supplementation, overlapping with these bony injuries, especially at this level when they're at rest. They start getting on the internet, they start looking at things, and I'm just curious on how you guys end up guiding them in some of these.
So I always, emphasize good nutrition, all the food groups. They ask about, different supplements. There are no studies out there, there's no supplement out there that we know that is going to prevent kids from developing overuse-related injuries, apophysitis. But I always do encourage, a healthy diet, multivitamin if the kids are picky eaters, and oftentimes athletes are really busy, so they are not getting all the nutrition that they possibly should be getting. And so, calcium, vitamin D, they're in, pediatric multivitamins. And so, those are important foundations for building strong bones in a young athlete. But other than that, there are no special supplements that we know of out there that will prevent these overuse-related type of injuries.
Dr. Chung, don't drop the mic yet. We have a question from one of our online viewers in regards to Severs. In regards to Severs, when do you use immobilization? What's the role for immobilization, and at what point do you decide that's something you would implement?
Right, so it's clinical. 99% of the time we don't immobilize kids with Severs, but there are some kids who will come in hobbling, not really wanting to put any weight at all, or they're just hopping around on the other foot. And so that's dangerous, right? You don't want them to fall and hurt something. So oftentimes we will try a boot, a cam boot to offset some of the pressure, or if that doesn't help and they're still having a lot of discomfort and pain, then you can try crutches. I think I've only casted like one Severs kid before where their pain was super, super severe, and but usually gel heel cups, stretches, icing, activity modification, that's what really helps them.
Great. Other questions in our audience here? Okay, we'll go to another one online then. Seems like all of you mentioned anti-inflammatories as a potential part of a treatment protocol. How do you guys walk the families through implementing the anti-inflammatories, and how long do you recommend that they're on them?
Anti-inflammatories as needed. If they are, actively symptomatic, then I think, doing a 7 to 10 day course of anti-inflammatories is reasonable. But if they are not having pain, or the pain only comes after activity, then just as needed. Yeah, and always encourage them to take it with food if they are taking anti-inflammatories, not to irritate their stomach.
I may just comment on that briefly, but I really, I think everything depends on the athlete and what the goals are. So, sometimes I may change my anti-inflammatory recommendation based on, what we're trying to achieve. Do we have a tournament in 4 weeks? Do we have, because these are inflammatory conditions, so you're not only treating the pain, but you're treating the process of how the condition occurs. So I don't hesitate to implement, particularly for an apophysitis around the pelvis, a 14-day course, and I like to use naproxen. It's easy. It's in the morning, it's in the afternoon, and we know it's well tolerated in children because the rheumatologists use this very, very frequently for very severe inflammatory conditions. So I like naproxen. I think it works very well. I don't hesitate to schedule a 14-day course, but I would say that I would tailor my recommendation based on what the goals are and trying to figure it out. If you can take a rest for 3 months, well, that's ideal, right? But if we're in a scenario where we have something that is important to the athlete, the parents, in which we want to try to modify our treatment to achieve a goal, well, I think that's what we do. We would individualize some of those cares based on the athlete and what the goals are at the same time, is trying to treat the overuse condition.
All right, we have one more question. Go ahead.
Really quick, yeah. So I noticed a lot of static stretching in your programs, but do you guys ever defer to an active type dynamic warm-up before actual activity?
When at all possible, I refer them to our excellent physical therapist for guidance.
No, I think that's really, so, yeah, I mean, I think I completely agree with your point, because I think we know now that dynamic stretching is really a valuable tool. The reality is it is a challenge sometimes to educate dynamic stretching, because that is something that can be overused so quickly, right? And so you can't, it's really easy or perhaps clinically easy to instruct static stretching, and that may be an easy solution to a common problem. But if we had resources available enough to actually make sure that these kids do proper dynamic stretching, I think we'd be more likely to do it on a routine basis. I'm always fearful to say, go do this dynamic stretching, because I don't think they know how to do it. They're going to end up pulling something if they don't do it correctly. So it adds a bit of complexity to go through the dynamic stretching. I think if you have a resilient course of apophysitis or a high-level athlete, utilizing all of our physical therapists around the community's resources to help us instruct them would be what I would do in terms of my practice. But for maybe some of your recreational athletes that just need a simple solution to a common problem, I think static stretching oftentimes will take care of the problem.
I lied, one more question. Recreational athletes, do you have some of those? We don't tend to see those very often anymore.
Do you see a difference or as far as recovery time versus or apophyseal problems in weight-bearing versus non-weight-bearing body parts? So like upper extremity versus lower extremity, does that take longer time, or is it about, it's just depends on the person, depends on the cycle?
Well, I think, lower extremity, both Osgood's and Severs can be really recalcitrant. They can take a long time, and I think it is, part of that weight-bearing or repetitive impact cycle. I mean, certainly with the upper extremity, you have more opportunity, whether they afford themselves the opportunity, but you at least have the opportunity to remove that, area from the repetitive stress. So, I think that those two are different. The pelvis, probably can be rested, from running and jumping and twisting things a little bit more than just the daily, walking or stairs that can sometimes flare up severs and the tibiotubercle. Yeah, sometimes families will struggle for 12 to 18 months with either calcaneal or tibiotubercle apophysitis. That can be common.
Any other questions? Okay, well, we really appreciate you guys coming out. We'd love for you to join us next month with Ray, who's going to cover pediatric and adolescent ankle injuries. Thanks again. Y'all have a great day.